Hi, my name is Mike Pishfine. I'm a GI medical oncologist at Johns Hopkins University, and it's my pleasure to be a moderator here for a GI oncology tumor board. And I'd like to go around and introduce the panel. I'll start with Dr. Zev Weinberg from UCLA.
Hi, my name is Dr. Zev Weinberg. I am a GI medical oncologist at UCLA, Los Angeles, California. Nice to be here.
And then from Emory, Dr. Pritesh Patel.
Hello, Pritesh Patel, Associate Professor of Radiation Oncology, GI Radiation Oncology at Emory.
From Memorial Sloan Kettering, Dr. Martin Weiser.
Hi, I'm Dr. Marty Weiser. I'm a surgical oncologist and colorectal surgeon at Memorial Sloan Kettering Cancer Center.
And finally, from Washington University in St. Louis, Dr. Carrie Siegel.
Hello, my name is Carrie Siegel. I'm an abdominal radiologist at the Mallinckrodt Institute of Radiology at Washington University in St. Louis.
Well, thank you all for joining us. It's going to be some very interesting discussion about some exceptional cases, and I think we should go ahead and dive right into it. This is a 54-year-old homeless female, current smoker, diagnosed with a T3N1 invasive squamous cell anal cancer. The staging scans were unremarkable except for an irregularly shaped nodule in the right middle lobe of the lungs. So what treatment could be offered to the patient and what would be recommended for that lung lesion? So the patient presented with progressive anal pain, hematochezia, and purulent anal discharge, but had a good performance status. As far as the medical history, there was a history of hypertension, asthma, and a history of genital and anal warts. The patient is a current smoker with 80 pack years of use, regular use of cocaine. She denies alcohol use. She is homeless and uses a local shelter only a few nights a week with no real family nearby, and there's no family history of cancer. The patients in September 2020, the anal pain and discharge grew and got, progressively worse. She presented to the emergency room in January 2021, where the CT showed an anal mass that was biopsied, but then the patient was not able to follow up with oncology for additional treatment plans. She re-presented to the emergency room in February of 2021 with worsening anal pain, hematochezia, and discharge. And the biopsy results were at that time discussed, revealing the squamous cell carcinoma. Shortly thereafter, an MRI of the pelvis was done, showing a T3N1 invasive anal cancer involving the posterior inferior rectal wall and the puborectalis and internal sphincter bilaterally, as well as a right external sphincter with obliteration of the intersphincteric space. The CT of the chest did show that 1.0 times by 0.6 nodular opacity in the right middle lobe. And we do have good imaging. We do have imaging for this. So Dr. Siegel, if you want to walk us through the MRIs and then the CTs of the chest.
Here's a sagittal image of the MR. And you can see there's a large irregular mass involving the anus, the rectum, and really extending into the perineum on this one view. I think if you go forward, I can show it on a coronal view. Okay, and here we can see that the mass is involving the internal sphincter, the intersphincteric plane, the external sphincter, levator ani muscle, and again, extending to the perineum. And can you go forward? So I'm not sure which pulmonary nodule they were worried about because there's a couple of small pulmonary nodules in the right lower lobe. There's a couple in particular. They are probably too small to biopsy. And they're probably too small in terms of FDG PET avidity. You know, they look to all be about 6, there's maybe 3 of them, and they all look to be about 6 millimeters. Sometimes we can get lucky, even though patients might be homeless, they might have had a scan sometime in the past, even a CT of the abdomen or a T-spine, and we can go back and look at those and see if those pulmonary nodules were there 4 years ago. Without having any information on time, it's going to be very tough to assess the underlying etiology of these.
And I think you've touched upon my point here with regards to PET scan and biopsy, but so in a patient who presents with a lung nodule, has a very strong smoking history, but also has a cancer that has the propensity to spread to the lungs, there's probably no good way radiographically to distinguish a lung primary from a lung metastasis?
Sometimes there's hints. The lung primaries tend to look more spiculated, and the metastases tend to be more rounder and smoother. The metastases tend to go in the direction where there's the most blood flow, so they tend to be more lower lung lesions. There's some things that can help you, but no, on an isolated one nodule basis, it's difficult to tell.
Understandable.
I mean, these could even be just inflammatory.
Yeah. Okay, so it's a difficult patient. Actually, to be honest, I've had exactly a patient like this, and I think one of the most difficult things to manage a patient like this is the fact that treatment for anal squamous cell cancer is a relatively long course of essentially daily therapy that a patient needs to be committed to. So Dr. Patel, what are your thoughts on local therapy for this kind of patients?
I think discussion with the group like we've just had about those nodules is really the first step. If it seems like maybe we're uncertain, we often proceed if the group agrees with giving the patients the benefit of the doubt and proceed with a definitive course. The pelvic disease is likely to be very symptomatic if it progresses, and so I think that would. Unless there's another diagnostic option for the pulmonary lesions, maybe giving the benefit of the doubt and proceeding would be my bias.
Gotcha. And Dr. Wainberg, what chemotherapy would you choose to give here?
Yeah, tough social situation, which, in someone with a history of active drug use, we're very loath to put a PICC line or some infusional option. So we're equally challenged by the fact that we're going to be worried about compliance with capecitabine. Mm-hmm. So it's a real tough situation. I agree. Ideally, this patient will be housed somewhere for the duration of the treatment. If that's not an option, at least for the first and last weeks when chemotherapy would be administered. That would be the way we've approached very unfortunate social situations like this one.
Gotcha. And just for you, would the treatment plan, let's assume that pulmonary nodule was biopsyable and did show metastatic anal squamous cell cancer, what would be your first-line chemotherapy for metastatic disease?
At this time, the first-line therapy for metastatic disease is certainly, most people would argue, 5-FU platinum-based therapy may be the first choice. People are moving slowly to immunotherapy. Maybe in this case, that would be something to consider as well. It might be a little safer and easier for this particular patient. But I will say that in someone like this with, at best, 1 or 2 very small pulmonary nodules that represent metastatic disease, I'm much more worried about the local control issue and would certainly still consider some radiation, if not for the cure, then for palliation, because the pulmonary nodules are unlikely to be this patient's problem anytime soon.
Dr. Patel, would not so much the dose, but would the number of treatments decrease if it was just palliative for if this was proven metastatic disease?
Yeah, I think a palliative dose would be much, much shorter. And more importantly, I think we'd want to sort of minimize the skin toxicity, which in this case, with extension to the perineal skin, the toxicity from a definitive course here is likely to be very significant. And there's some thought that for T3 or these very large tumors, that you really should be going higher than the standard 54 gray because there's just a much higher rate of recurrence. So often, I'll try to reach 59 gray or 60 gray, depending on how the patient's doing. So that type of skin toxicity with this very extensive involvement of the perineal skin is going to be very difficult for this patient. So if we were in a palliative mode, absolutely, I'd want to reduce the dose to minimize that risk.
Gotcha. All right. Well, it sounds like the panel is in agreement that we should ideally treat this patient and give the patient the benefit of the doubt if we can't, quote unquote, prove that the lung nodule is a metastatic lesion And so it would be standard chemoradiation, ideally with 5-FU and mitomycin, but it would be really, really challenging. And I think the social work team would really have to be involved to make sure that the patient was compliant and able to be delivered all of the therapy that she would need. And then also if the patient did have metastatic disease, proven by biopsy of the lungs, that there still would be a role for palliative radiation therapy, and the chemotherapy might not be tremendously different. Maybe 5-FU cisplatin in this case, maybe other regimens like the recently presented carbotaxol regimen could be presented as well, but compliance is going to be one of the biggest issues of all.